Okay. Well, welcome everybody this morning. Hi, Carol. Hi, Martin. I am appreciative of all of your time and for everybody joining us in the audience. And welcome to day 2 of our Washington Patient Safety Coalition Conference. I'm Ginny Weir, CEO of our Foundation for Healthcare Quality. I use she, her pronouns. I'm also wearing contacts. I have very bad eyes, and without that, I wouldn't be able to see anything. So I appreciate the movement to sort of for folks to describe themselves visually for people who might similarly not be able to see as well. So I have brown hair, light skin. I'm wearing my fall maroon colored clothing. And I also want to start out by acknowledging that we are on the traditional land of the first people of Seattle, the Duwamish people, past and present. And we honor with gratitude the land itself and the Duwamish tribe. I would also like to acknowledge the federally recognized Muckleshoot Indian tribe, the ancestral keepers of the land we're gathered on today. We thank them for their immense contributions to our state and local history, culture, economy, and identity as Washingtonians, and feel that we have an ethical obligation to consider our history as a country and be an equity first organization that really acknowledges both history and trauma to all peoples throughout our country, and especially those who have experienced specific historic trauma. And with that, again, welcome our speakers and welcome our audience members. Appreciate your time today, and I will turn it over to Jonathan Stewart.
Thanks, Jenny. I'd just like to add my welcome on behalf of the Washington Patient Safety Coalition and our regional partners, the Oregon Patient Safety Commission and the British Columbia Patient Safety and Quality Council. Thank you for being here. Also, our deepest gratitude to each of our sponsors. Your generous support is what makes this conference possible, so thank you. We have another great program lined up today. Very excited to get started. So I'll turn it over to the Executive Director of the Washington Patient Safety Coalition, Steve Levy, to introduce our first speakers.
Thank you, Jonathan, and thank you all for attending today. The session's being recorded. Please use the Q&A function at the bottom of the Zoom screen for questions. Chris Smith from the BC Patient Safety Quality Council will field your questions at the end of the presentation. It's my pleasure to introduce our speakers for this session, Marty Hatlie and Carole Hemmelgarn. Marty is a lawyer by background and currently serves as CEO of Project Patient Care, which is the Chicagoland Safety and Quality Improvement Coalition, dedicated to using the voice of the patient to improve care. He also serves on the Patients for Patient Safety Advisory Group, part of the World Health Organization's Patient Safety Program. He's engaged in a number of boards and advisory roles with the Leapfrog Group, National Quality Forum, and the Joint Commission. Marty coordinated the launch of the National Patient Safety Foundation in 1997 and served as its founding executive director. That brings back memories. Carole Hemmelgarn is the director of the Executive Master's Program for Clinical Quality, Safety, and Leadership at Georgetown University and the Senior Director, Education for MedStar Institute for Quality and Safety. She has worked in healthcare for over 30 years. Carole, I don't know if I'm supposed to say that. You don't look a day over 20.
Thank you.
Her area of focus is in communication resolution programs, storytelling in healthcare, and the aftermath endured by providers, patients, and families when medical harm transpires. She sits on the Leapfrog Patient and Family Caregiver Expert Panel, Board of Quality, Safety, and Experience at Children's Hospital, Colorado, Clinical Excellence Council for Colorado Hospital Association, is a founding member of Patients for Patient Safety US. Carole, Marty, Susan Sheridan, and Beth Daly Ulam wrote the provocative opinion piece, Who Killed Patient Safety, in the May 5th edition of the Journal of Patient Safety and Risk Management. You're going to hear lots more about it right now. So Carole, it's all yours.
Thank you. And you're perfect. Well, welcome everybody. Marty and I are really excited to be here today to talk to you about our article, Who Killed Patient Safety? But for any of you that are musical or movie lovers, we have to be like The Sound of Music, and we have to start at the very beginning to understand how we got to this point in the article. So that takes us back to May of 2021, when a group of us, if you'll go to the next slide, please, gathered at Sue Sheridan's home in McCall, Idaho. 6 of us, of the founding members, all of us were frustrated with the direction that patient safety was going, but 6 of us were able to meet. And during this time, we were all doing things independently, sometimes doing things together, but there was frustration that patient safety hadn't just drifted, which is a term and what we're hearing a lot today. It had actually disappeared from regulatory, national agendas, government, and hospital. And we were frustrated because patient safety needs to be always there. We were also very disappointed to see that our leadership had let it fall off of their agendas. And we spoke up and decided that we needed to make a change. So we're a seasoned group of patient activists, but we were all doing our own different things. And we realized that over the past 20 years that there hasn't been a lot of change in the patient safety realm. We all know To Err is Human that was put out by the Institute of Medicine. And we know that we've looked at it in 5 years, 10 years, 20 years, and we've seen that there have been some changes, but not as much as we would like to see. So while we were all there together, at the same time, WHO, the World Health Organization, had also put out there that they had created what they call the Global Patient Safety Action Plan, and that they were going to be focusing again on patient safety from 2021 to 2030. So Marty and Sue had done a lot of work and were part of WHO, but we in the United States had not had a Patients for Patient Safety US entity like many other of the countries had out there. So because of that, we formed Patients for Patient Safety US to align with WHO and their initiatives, which also aligned with our initiatives as a co-founding group of what we wanted to do in patient safety. The Global Patient Safety Action Plan has 7 strategic areas they're focusing on. And then under each of these, they have 5 different priorities, and they will be measuring these every year. So people will say, why another group? Well, we know there's many groups out there. There's groups that are focused on disease states that are patient activists. We know there's other patient safety groups out there. But one of the things that we realized is that we need a bigger collective voice if we're going to tackle patient safety at the national level. And with that, we mean at the government, at the private entities. And so with that, we have these original 10 founding members, but now we have nearly 50 champions that are joining us. So our voice is getting stronger when we go out and try to push these different issues. Which that now takes us to who killed patient safety. So while we were all together, we realized that we needed to write something. We needed to put our voices out there and show that we were frustrated and not happy with how we saw patient safety going. So while we were there, we started talking about what were the key areas and topics that we wanted to talk about. And we realized that we needed to address government, regulatory, and the private entities, because you see, we saw that on the national agendas for NQF, CMS, IHI, that there weren't strategies around patient safety. In fact, many organizations had deprioritized, defunded, and deprogrammed a lot of the work around patient safety. But the other thing that's interesting when we were starting to research our article and talk is that this wasn't just our conclusion that patient safety had drifted and disappeared. The National Academy of Science in 2021 also wrote an article. And one of the things that they said is that We believe the country is at a relative standstill in patient safety progress. Although the original To Err Human report commanded national attention more than 2 decades ago, the country has not achieved the level of safety in daily patient care that we have come to expect, like other industries looking at aviation. Continuing on this current trajectory is not likely to produce substantial improvement in patient safety. So the WHO also made a comment about strategic priorities. And what they said is make zero avoidable harm to patients a state of mind and a rule of engagement in the planning and delivery of healthcare everywhere. In the US, we avoid oftentimes the term zero preventable harm, but we shouldn't. That's what we're trying to achieve. So Marty and I are here today. We want to be provocative with you. We want to talk with you about how do we challenge and change the status quo? And how do we do this discussing the role that patient activists and what we need to do in moving this patient safety agenda forward? Because you see, we believe that patients and families are the social revolution that is needed to make healthcare safer and also to achieve zero avoidable harm. Next slide, please. So here is our commitment as part of Patients for Patient Safety US. We want to engage all stakeholders. We want all patient and family voices. We want to address equity, diversity. We are open to participating and engaging anyone that wants to help us join in pushing this work forward. Next slide, please. So there's 5 different buckets that we're going to talk to you about today that align with our priorities and also the paper, Who Killed Patient Safety. The first one is, we don't believe anyone is in charge of patient safety. The second is the problem with reporting and data collection. The third is patient engagement. Fourth, transparency. And the final one is leadership. And with that, I'm going to turn it over to Marty to talk about no one is in charge. And if you go to the next slide, please.
Thanks, Carole. And Jenny, I have to tell you, I really appreciate your opening remarks because I'm sight impaired as well. So you reached at least one person with your welcoming remarks, and I can't tell you how much I appreciate it. So I'm going to build on Carole's comments about how frustrated the 10 of us were that came together. I'm sure many of the people participating in this event today were part of the Partnership for Patient Safety, which was, one of the many things in the Obama administration that really prioritized patient safety. In the Affordable Care Act, there was a lot of emphasis on patient safety. There was research grants, there were demonstration grants. There was the Partnership for Patients, the largest collaborative on patient safety ever in the world, as far as I know. So it was a priority there, and it did drift. And one of the things that really prompted our article was looking at the new strategic plan that was put out by the Department of Health and Human Services last year, which didn't even mention patient safety. The NQF strategic plan, and let's remember that NQF was really established to drive patient safety. They had really troubling verbiage in their in the commentary of their strategic plan issued last year that said, we've spent too much time thinking about safety and not enough about other priorities. So we're going to shift to health equity and the opioid crisis, and maternal and child health care. And we really were alarmed, frankly, that those other issues were being put up as competitive with patient safety, because they are all system safety issues. So that is, really what got our attention. And the data that we continue to see shows that all the progress that we made during the Partnership for Patients, and it wasn't enough, but it was significant, completely drifted. And it wasn't just COVID that made it drift. It was just the lack of prioritization that Carole talked about. So that's kind of the alarm bells that were going off in the US. At the world stage, I mean, WHO has prioritized patient safety since 2002. They put out a call to action saying this should be a global priority. Every country should be involved. Most countries were for many, many, many years. It was a very well-funded program. In 2018, Lancet published an article based on 2016 data from the the Global Burden of Disease that showed for the first time that in 2016, more people in 131 countries were dying from poor quality and unsafe care than from lack of access to care. And that was just a shock to the world public health community. I mean, WHO's core mission is making sure that every human being on earth has access to healthcare. And suddenly we realized in spades, looking at the data, that we're bringing people into unsafe systems. So by improving access, we're actually endangering them in other ways. And that's what prompted a new resolution at WHO that produced the Global Patient Safety Action Plan. Now, the first strategy, Carole mentioned there were 7 strategies in this plan, and it's a beautifully written document. So I would encourage all of you to look at it, and they all synergize all 7 strategies. But the first one is really making sure that that national governments, state governments, local governments prioritize patient safety. And when we look around, and we hear this from, Carole and I hear this from consumers all the time, we hear that there's nobody in charge. When we as a patient or family member want to report something, we really don't know where to effectively go to see that that report gets followed through on. We don't know who's in charge. In our country, we have this divide between the states and the feds. So that's one area where there's just a lack of coordination. You can have great leadership at the federal level, for example, and the states are, regulating in their own ways. We've seen efforts in the past to try to coordinate what happens within states. The Betsy Lehman Center in Massachusetts tried to bring all of the regulatory bodies that touch health together under one umbrella there. That fell apart. At the federal level, even during the Obama administration, when this was a #1 priority, it was hard to get all of the federal agencies to cooperate or to even talk to one another. Those of you who were involved in that campaign will remember that we tried to bring the federal partners together to just to kind of coordinate and align. So having somebody in charge is a real issue. Having someone coordinate amongst the different jurisdictions is a real issue, and it's the #1 strategy of the Global Patient Safety Action Plan. So it's not just an issue for us here, it's an issue for us in many, many nations on Earth. I want to say one more thing too, because we're going to talk about it a little bit later, but the Vanderbilt case, which has gotten everybody's attention, is a good example. I mean, that is a state, Tennessee was a state here, where we had the nursing board doing one thing, a local prosecutor going after a nurse with no coordination with the nursing board or with CMS or with CDC or all the other agencies that should have been having some kind of oversight around that issue. And I just mentioned that because I think it's very top of mind for a lot of people in the safety field. None of us wanted to see Nurse Bont get prosecuted, but the lack of coordination that allowed that to happen is a systems issue. In this country, we have some initiatives out there to kind of align with and achieve this #1 strategy, the Global Patient Safety Action Plan. For those of you engaged in the Patient Safety Movement Foundation, you know that they called for a moonshot. We've been talking about the connectivity between the different safety regulators and safety investigators in the aviation industry as a model for us for at least 20 years. I remember calling for it in an article I wrote in 2004. So, and there were people before me who called for it. So that is sort of the essence of the moonshot, is let's put together a national strategy here in the United States that really prioritizes patient safety as a major public health threat and put all of our resources behind it. There's also a really interesting coalition that's being supported by the Jewish Healthcare Foundation in Pittsburgh. It's called the National Patient Safety Board Coalition. It's not a full aviation model. It really picks that National Patient Safety Board or that National Transportation Safety Board as a model, and calls for the creation of a board, a similar body in healthcare to really look at all the data, take reports, and then use all sorts of different tools, including technological tools that are coming online to really look at data, look for patterns, and then make recommendations to every jurisdiction in the country. And we at Patients for Patient Safety US are a strong supporter of that bill. And finally, I want to just say this, Carole and I wrote this article to get the Secretary's attention when we didn't see patient safety prioritized in his strategic plan. And we've been working with a lot of other groups that I think probably many people in this phone call to do some of the same things. And we do have a really promising development with a working group on patient safety that's part of the Presidential Council of Scientific Affairs that is meeting right now to make recommendations to President Biden. So there's a lot of reason to be hopeful that we are going to see the kind of leadership that we need in this country moving forward. Carole, do you have anything to add? I think we're kind of at time for this segment, and I just want to pause to see if you want to, if I made any mistakes or if there's any omissions you want to jump into before I go on to the next one.
No, I think the biggest thing is the article really did stir a lot of people, and we were out there pushing it. And it's funny now how there's traction coming. Where oftentimes patients and families don't get credit for some of the things we do, but we think and believe that we were the impetus on some of the things that patients and families have been asked to be involved in and bringing it back to the national forefront.
So Carole, maybe we should share our strategy with how we got the Secretary's attention. So we, at the time we wrote this article, we also wrote him a letter collecting all of the data we had, because we didn't know his background, Secretary Becerra's background in patient safety. He was, an unknown quantity to us. That letter didn't get answered. So we sent it again in January. It didn't get answered. And so we sent it again in July, and we copied the chairs and the ranking members of all of the relevant committees in the Senate and the House and all of the subcommittees that touched health. So that would be Appropriations, Ways and Means, Energy and Commerce, the Health Committee in the Senate. And we don't know for sure if that's what got his attention, but we did get a response to that. And so just for those of you who are in the advocacy business, I would recommend that as a strategy. Okay, let's go on to our next topic, which is reporting. And great. So many of us in the patient safety movement believe that preventable harm in healthcare from medical errors or systems failures is the third largest cause of death, but we don't know that because we're not counting. Those estimates are based on studies, research studies, and most of the research studies have been done in hospitals. So not all the settings across which there are healthcare services delivered. We're now in a competition in sort of the arena of public opinion about whether COVID or patient safety is the third largest cause of preventable death over the last couple of years. And we're at a disadvantage because COVID deaths are actually counted. CDC follows them. They follow them not just in hospitals, but they follow them in nursing homes where a lot of those deaths occurred. If we looked at the data, there's a whole series of reports that came out of the CMS OIG's office that show that that if we think hospitals have a ways to go to become safer, my God, let's look at long-term care facilities, rehab hospitals, nursing homes, long-term care hospitals. The rate of preventable harm in those places are underappreciated and not counted when we talk about the estimates that we've got. So it is one of the things we're going to be asking for is how can we measure progress if we can't even have a baseline for how much harm is actually happening? It's like, playing a game without any ability to keep score. Another thing that we have talked to CDC about, because Carole mentioned, we're talking, this group of us that came together started dialogues with every agency that we thought had some jurisdiction here. And CDC should be the place where things are counted. The best counting happens at HRQ right now, but it could happen at CDC. They certainly have the jurisdiction. And one of the tools they could use are death certificates. But we know that preventable harm in healthcare is not a field that is usually triggered in death certificates. There's not a check the box place. You've got to enter it narratively. This is not just a problem in the United States. It's a problem in other countries as well, but we're just not capturing that data in our official death certificates. If we were, I think it'd be easier for us to make the case that this was the third largest cause of preventable harm, of true public health crisis. And one of the things I want to share with you is a new model that's coming forward in the UK, because it really connects to patient engagement, which is what really gets Carole and I going here. They've got a plan rolling out just last year called the medical examiner model. And what they've done is they've trained somebody in every one of their trusts to actually, and they were trained by the Royal College of Pathology to actually do a very good event analysis before the death certificate is filled out. And part of that analysis has to be a conversation with the patient or the family members before the death certificate is filled out. We think that's kind of a Trojan horse, that will get much more accurate death certificates, because often patients don't even know, or families don't even know what's in the death certificate until it's already filed with the regulators. So I'm happy to send information around about that medical examiner model. It was it's having a cultural impact, just because this is the process that has to be done. It's making people take the whole process of filling out the death certificate more seriously and doing better investigations. At least that's the preliminary findings from it. Another thing we wanted to mention is that reporting just isn't happening where it's supposed to be in this country. I keep pointing to the fact that Indiana and Minnesota have almost identical reporting statutes. It's built off of the NQF never event list. They also happen to have almost the exact same number of hospitals in the state. So they're very comparable. And yet we routinely see at least 200 to 300% more reports filed every year annually in Minnesota than in Indiana. And it's because Minnesota has made it sort of a community priority. The Department of Health reminds the population, the general public, when the report comes out every January, that these are the good hospitals. These are the hospitals that actually report. These same things are probably happening in other hospitals that don't report. So they're engendering that kind of trust in the general public, and that kind of understanding of why reporting matters and why systems matter. And that's just because of advocacy. There's been effective advocacy in Minnesota of groups like the Washington Patient Safety Coalition working together with the Department of Health and the QIO and the Hospital Association to really make that reporting matter. But the discrepancy between the two states is bothersome. I mentioned Vanderbilt before. I mean, it was a serious safety event by any measure that happened at Vanderbilt, and yet it wasn't reported to their state. And when we've talked to the people at Vanderbilt about it, they basically said that they were not reporting because other hospitals in their state weren't reporting things like this either, and they would look worse if that were happening. And that's just not an acceptable kind of positioning, and it's been normalized, I think, not just at Vanderbilt, but in many other places that you go, oh my gosh, we're not going to report. It's going to make us look bad. And so it's just one other way in which reports are suppressed. We also don't know, we'll talk a little bit more about PSOs in a later segment, Carole. I know we're at time here, but we also know that the PSO program, if they're doing anything, and I believe they are, I believe that they are collecting data and using it internally, but we have not seen the data shared nationally the way we expected it to. So from the public's point of view, we don't really know what kinds of results the PSOs are delivering for the systems and for the organizations they work with, because it's just not transparent to us. So Carole, I'm going to stop there and pass the baton to you for our next issue, unless you have some color commentary here.
No, I don't. So the next one, if you'll go to the next slide, is we realize the importance of patient engagement. Now, many different people have different definitions about patients and patient engagement, but we look at it at all fronts of healthcare. What's interesting, though, when you talk to different patient activists, is the fact that in the beginning we were tokens, or there was tokenisms. We wanted to be in the room where it happened. But in order to be in the room where it happened and to have a seat at the table, we oftentimes had to trade our voice so that we could just be there. And now we're realizing, we have traded that power, and now it's time for us to speak up. And it's also because there have, over the years, been this iteration of engaging patients and families in different roles, different committees, different seats. It used to be there was one, now there's two, but we need to drive that even more. There should not be anything done in healthcare where a patient or family are not part of it. One of the other things is we keep hearing about what has transpired the last 20 years, the private-public partnership. And we know there have been some great changes there, but not enough. And we don't think it's working. But if that is the trajectory that is still going to be followed, then it needs to be the 3 Ps. It needs to be the public, private, and patient and family partnership, because this work cannot be done without us. Patients and families are the 4.0 of what is going to take healthcare to the next level. And oftentimes people forget, they think of us as just patients and families, and yet we all have backgrounds and experiences and histories of things that we can bring. Marty is a lawyer. I work in education, worked in healthcare, other people in banking, some are consultants. All of our knowledge contributes to improving healthcare. And we know that healthcare cannot solve these problems alone. We're looking at other industries to help solve the problems. The other thing is co-production. There should not be guidelines done without patients and families being part of it. Policies created, work streams. Co-production is so important, having the patient and family voice. And we are seeing it come out more and more when PCORI did the work. And there's not research done through PCORI where there are not patients and families as part of it. Patient and family engagement stratifies all the different levels in healthcare. So those of you that are patient activists on this call, we encourage you to push your voices, push the organizations you work at to make sure patients and families are on the various committees. And I know all of us that are part of PFPSUS, we literally have a strategy on making sure we have people sitting on the CDC like Armando Nahum, on NQF, part of IHI, anywhere that there are decisions being made, that patients and families are actually active participants in that work. Marty, do you want to add any comments to that?
Well, Carole, I'm glad you mentioned Armando Nahum, because he's also one of our co-founders, and we know he's going to be presenting to this August group after we're done. And I do want to just pick up on the fact that you are using the word activist very deliberately and intentionally today. So, and I love the point that you made about sort of trading our voice, our power for a seat at the table. I think that happened. When I look at all of the different frameworks that are out there about patient and family engagement and how it matters, it kind of slots us into 2 categories. One is, being partners at the point of care, where, we're doing the best to get the best results for ourselves or a person that we love. And then bringing our experience and our wisdom into improvement work. So there's been a lot of great work there. In fact, that's what Armando is going to be talking about. But what we haven't done is been activist. We haven't used our voice to protest the way that other consumers have. And I think we kind of bought into the fact that we were going to be partners. We were going to trust that public-private partnership. We were going to trust that leaders were going to keep this as the priority. We've seen some leaders keep it as a priority, but not system-wide. And so it is time for us to raise our voices. And, as you know, Carole, I'm just kind of sharing this with the group, that is why we came together, because we were too quiet for too long. We have some of the responsibility to really make this a priority by raising our voices. And what's been really interesting since we launched Patients for Patient Safety US last year is the number of agencies and people that know us who are coming to us saying, can you please say this? Because we can't. Can you please make a complaint about the Vanderbilt case to the OIG because we can't? Can you please speak up to the secretary because we can't? It's just a really, really interesting position that we find ourselves in as activists. So I'm excited that we're going to be building out that dimension of our power as we go forward. Yeah. And we're still going to do it as partners. I mean, we're going to be partners with anyone who wants to prioritize patient safety. We're going to be just maybe a little bit pushier as a partner than we were in the past.
Well, our voices are collective voices, where before they were independent, and it gives more power when there's a collective voice. So if you'll move on to the next bucket. Thank you. So the next one is around transparency, and this one is near and dear to my heart. We toss transparency out there, but we're not seeing transparency. And again, we can go back to what happened at Vanderbilt. Transparency in healthcare is so important because transparency is aligned with trust. And we know that we are losing patients and families are losing trust in the healthcare system. We know people of color, brown and Black, have not trusted the healthcare system for many, many years. And there's many others now that are starting to not trust the healthcare system. And so part of that is the lack of transparency. The area where I really focus on transparency is after medical harm, because we know that many organizations do not have a strategy on how to talk to patients and families after harm. And it is so important that we are having these conversations, because when patients and families don't know what happened in their care or loved ones, they often carry the guilt. And for some, their only way to get answers, if the organization's not going to tell them, is to go down the path of litigation. And this is not the right way to go. Organizations and providers have a moral and ethical duty to talk to patients and families after harm, because we'll often say the first time when you harm us, it's unintentional. The second time, when we're lied to, met with silence, or information withheld, that's intentional. And that is just a second form of compounding harm that you do to patients and families. Marty, do you want to talk a little bit about the gag clauses?
I do, Carole, but I also, before I do that, I want to comment on what you said. I mean, looking back for the last 25 years, we have seen these inspiring stories of transparency that happen periodically. And the first one I remember is the Ben Kolb case at Martin Memorial Hospital in Stuart, Florida, back in 1997. Complete, open, honest communication, not just with the family, but a promise to the family that they were going to tell what had killed Ben Kolb, the 7-year-old boy who had an anesthesia event in the OR, so that other hospitals could learn from their experience. I mean, it was that kind of leadership that we just appreciated. For those of you who know Julie Morath, I mean, the work that she did on transparency at Children's Hospital in the Twin Cities won them the first Eisenberg Award. Here in Chicago, where I live, we had the kind of beginning of what became the Candor program, the 7 pillars. Carole, you and I were both involved in that, but a commitment from a major teaching university to be open and honest wherever their event told them that medically they hadn't met the standard of care. They were not going to fight that in court. They were going to open up dialogue and a compensation discussion with patients and families. And that evidence is accumulating. I mean, Jonathan Stewart is here. When liability insurance companies like Beta Healthcare start incentivizing open and honest transparency, you know there's a business case for it. Although I think there's also a great moral leadership at that company. So the evidence is accumulating that transparency is good for business. It's good for generating trust. It's good for your workforce, and yet we're still not seeing it happen systemically. So I think that has to be something that we just all just commit to in going forward. And then, you know, why aren't people transparent? We do have these sort of systemic drags on transparency, and one of them is gag clauses. I mean, that's still a normalized procedure. That should be, and by gag clauses, I mean the confidentiality agreements that patients and families are forced to sign, that they're not going to talk about something after a settlement of a case. I think those are morally wrong. Those from a systems point of view, they bury our treasure. They bury the information that we could be sharing about what went wrong in our organization so other hospitals can learn. They should be, they are contrary to public policy. They should not be as routinely used as they are now. And kind of branching off from that, if you look at our legal system, I mean, our legal system is adversarial. It's not focused on looking at all the facts objectively to figure out whether there was a breach in the standard of care. It's focused on winning. And we continue to see hospitals spending much more money defending cases than it would take to settle them. And that's just crazy, not to mention morally wrong. So I understand and I empathize with healthcare systems that are in jurisdictions where there's a lot of litigation, but the ticket forward is transparency. It's moving forward. We can operate in the shadow of the legal system. I think we should also be really looking at our legal system. That'll be a tough nut to crack politically, but it's an important thing to do. And there are proponents out there for no-fault systems in healthcare in this country, and we have models internationally of it working really well in a half a dozen countries. where you don't have to show that there was fault. You just show that there was an unexpected outcome that shouldn't have normally happened. And then we do have to talk about the PSOs. I mean, I know it's a major policy win for patient safety. It's one of the few pieces of legislation that actually has been implemented in a big way, but the lack of transparency, I do think, is really troublesome. There was a deal, I believe, with the American public that we were going to give PSOs the protections that they have to do analysis in exchange for them sharing data across PSOs with each other so we could all learn systemically in the country. And that's just not happening. Of the 90 PSOs, that National Academy of Sciences report that you cited, Carole, says that only 3 are reporting to the National Patient Safety Database. And I just would call on everybody here who's a fan of PSOs to join with us in understanding how we can make that better, because there could be just fantastic data there to improve safety that we're not harvesting in an effective way. It's too siloed. So Carole, I think we're a little bit behind time, but not too bad, all things considered. Should we move on to leadership?
Yes. So the final one we want to talk about is we know most things in healthcare aren't going to get done if you don't have leadership support and buy-in. And unfortunately, we have seen, again, as we've talked about earlier, the drift in leadership supporting the different patient safety initiatives. We also are very aware in healthcare, and sadly, is what is measured is oftentimes what gets paid for or what CMS is putting out there. And patient safety sometimes isn't a payment structure like other measurements. And it shouldn't have to be. It should be the moral imperative that patient safety is just infused in every system, whether it is paid for or not paid for. So leadership really has to drive this, and that starts with leadership at all levels, at the presidential level, that is a priority, at the governmental level, at the Health and Human Services, at CMS, at IHI, at all of the different entities that we all agree patient safety is a fundamental baseline for patients and families, anyone walking in to touch the healthcare system. Marty? I'll let you talk about the Safer Together.
Yeah, Carole, I also just want to say a little bit more about measurement. So one of the things that we're seeing in the NQF process, for those of you who follow it, CMS takes a list of measures that they want to put out into the field every year to NQF and put it through what they call the MAP, the Measures Application Partnership. And different groups look at the metrics that CMS has proposed. And 3 years ago, I guess, CMS just was looking at the data on maternal and child health care and not knowing exactly what to measure. I mean, the measures just weren't mature enough, but they wanted to do something. And so they put out a structural measure, essentially calling upon every hospital to prioritize maternal and child health because our numbers are just terrible. And last year, they took a similar approach with health equity. I don't know how many of us really realize that the data that hospitals collect on the basic social determinants of health and race, ethnicity, language, age, sexual orientation is just all over the place. It's not well collected. CMS doesn't even have data they can make sense of. When they talk to hospitals say, well, CMS is collecting it. They don't realize that they're collecting it through the hospitals. So this year, CMS put into the NQF hopper 3 new structural metrics on health equity and social determinants, really requiring hospitals to collect that data, requiring hospital leaders to prioritize it, hospital boards to have oversight, and not just collect the data, but analyze it and use it in improvement work. And I think that's a good model for patient safety. If we could use that kind of metric coming out of NQF and CMS to really help use their leverage to reprioritize safety the way they did it during the Obama administration, it would be pretty much a dream come true for me. So I hope that happens. We do have an action plan on patient safety that has been put together by IHI and HRQ. It hasn't gotten the attention it deserves. It's not incongruent with the World Health Organization action plan by any means, although we think the World Health Action Plan hits that government prioritization issue harder than the IHI HRQ one does. But the promising development that's on the horizon right now is that, you know, I don't want to take too much credit for it, but I do want to take a little bit of credit. Because we were so persistent in chasing the secretary, we did hear back and finally got an answer to our letter. And that letter, that answer was an invitation to actually participate in an event on November 14th, where the Secretary of Health and Human Services is going to come. Armando Nahum is going to be a speaker there, and call upon the largest healthcare systems in the country to make patient safety a priority. So we don't have too much information about it, but it's not very far off. It's November 14th. So it's a really significant and sort of hope-inspiring for me step forward to really advance that action plan that we do have, which again wasn't even mentioned in the strategic plan that the healthcare, that the Department of Health and Human Services put out last year. I couldn't agree more, Carole, that the public-private partnership, you know, hasn't worked. At least it hasn't worked consistently. It hasn't worked systemically. I believe it's worked in some places. I mean, we know the leaders in the field that are doing high reliability work and transparency and patient and family engagement, but it hasn't happened systemically. So we need that to happen. And I don't think that's going to happen without advocacy, not just from patients, but from the healthcare workforce that also are entitled to work in safe systems. So I'm really excited that we have some attention being paid by HRQ, Health and Human Services, and also that president's Council of Advisors on Scientific Affairs.
And Marty, we have CMS too. I think we have to say, CMS, all of the different entities are talking with us, and, you know, we're trying to figure out how do we get patient safety back to where it should be.
Yeah. We have reason to believe that they are working on the structural metric on safety that will be put through the process next year. So yeah, we'll wait and see if that happens. But you know, the dialogue has been promising, I think.
So with that, what we want to do is we want to open it up to you all in the audience, because when I said early on, we wanted to talk with you. And how do we, as a collective group, change and improve the status of patient safety? So if we want to just put us full screen and take the slide down, we want to start to answer questions from the audience.
We've thrown a lot of ideas out there today, so and we're not shy. So if you disagree with us, that's great, but we'd love to just dialogue with you, because you're one of the major coalitions on patient safety in the country. There's really not too many states that have anything like this coalition, so we're really eager to hear from you.
Okay, so I see there's some questions. Steve or Nick, were you going to prioritize the questions? Okay, I can actually look, Marty. So the first one is, can you comment on the role of the private employers, purchasers of insurance for their employees in promoting patient safety? Good question. You know, one of the things that we talk about is we know that CMS, we know that the government can control certain things, right? They have the military, the DOD, the VA, Medicare, Medicaid. But that question is a really appropriate question, because there's a whole other part of the private sector and your health plans, your Uniteds, Aetnas, Anthems, Cignas, where how do we get them to be prioritizing safety along with the governmental side? And we haven't cracked that nut, but we feel like they have a lot of power. If they didn't start paying for errors, that would be another unique way of doing it. You know, but how is that structure implemented in there that it's fairly based? Yeah.
Sharon and everybody, I just rotated off of a 12-year stint on the board of the Leapfrog Group, and this is why the Leapfrog Group was invented. It was because there's a clear interest of private employers to make sure that their healthcare workers and their families, you know, are well and not absent from work because of problems that have happened in their healthcare. So there's a clear interest, but it has been a heavy lift. You know, again, with with some really strong coalitions of employers in certain states, New Jersey, New York, for example, and then other states where it's absolutely fought. And it's usually, I don't mean to vilify anybody, but it's often the hospital association that's fighting it. So I think it's a worthy mission. I think the interest is there. And I'm hoping that, again, if the public starts raising their voice about the importance of this, employers and their HR departments will pay a greater deal of attention. I think it's a very, very worthy avenue for us to pursue.
Marty, one of the next questions is, and how do we deal with the financial case for not doing much on patient safety? In other words, patient safety is a cost center. It's not a revenue center.
Yeah. Well, I don't have a complete answer to this. I've never worked in a hospital, and whenever I look at the way hospitals do their accounting, it just mystifies me. But one of the things that happens way too often is just the whole liability cost center in a hospital accounting is just often a separate silo. They don't connect it to the quality or the safety of their care. I already mentioned two of our co-founders, Margot and Steve Burrows, are the filmmakers who made Bleed Out. If you haven't seen that movie, pour yourself a glass of wine or something stronger and sit down and watch it, because it is an expose about how much we spend on litigation in this country. The woman who died in that case was a 70-year-old retired Wisconsin school teacher. The system fought it for 10 years in court. The standard of care was clearly breached. Think about if they'd spent whatever they spent on lawyers for 10 years. And I'll tell you, it was millions of dollars on improving the quality of care or doing things to take care of their workforce. It would be a very different state. So I don't have a complete answer to this, Sharon, or wasn't Sharon who asked that question, it was somebody else. But I'll tell you that looking at your litigation costs and looking at the data coming out of Beta Healthcare and other places like the collaborative, Carole, that you're involved in, that shows a consistent sort of financially reasonable package of benefits that you get from transparency, I think is a really good place to start.
I think the other thing is that we always have to keep in mind it's hard to track that, but if we're learning, we're less likely to make those mistakes that are costly. So keeping that we're always should be in that learning mode in healthcare. Again, it's hard to always prove that financial benefit, but it shouldn't have to be proven. It should just be a norm that is expected.
Carole, I'd also say, I know the Leapfrog Group in their grading system is controversial because it's not perfect. It relies on data that is sometimes a couple of years old. I understand all of that, but it does create an incentive for organizations to invest in safety by publicly reporting at least one organization's opinion about how safe you are. And my domestic partner is a hospital CEO. He can't achieve safety there without an investment in safety. He can't get a good grade on Leapfrog Group without an investment in safety. So I think there are things we can do to kind of build that business case, especially as the prominence of the Leapfrog Group grade continues to grow.
So we've got a lot of questions coming in, Marty. I'm just going to make a couple comments and then I'll throw out another one. Someone typed in, they're a patient advocate, not an activist. I think the vernacular does matter. And if you want to be a patient advocate, we applaud that. If you want to be an activist, we applaud that. It's just collecting everybody's voice, that everyone has a voice to speak up and, advocate for themselves and their loved ones when it comes to healthcare. So Marty, here's a question. The NTSB is a great model, but the events they investigate are fairly dramatic and hard to hide. Sometimes patient safety deaths are rarely so dramatic and are easier to hide. How do we address this?
Well, we've got a lot of tools to address this. I mean, some of them are the work that's happening in the private sector around predictive analytics, where they're actually going into databases and screening electronically for things that are just that should be better outcomes than they are. I mean, the registries that a lot of specialist societies are keeping now about the performance of their members is another database. I mean, they know who the outliers are, the people who could use some improvement in skills. So I think, looking at that broader swath of data in the EHR and other databases is a way to get at some of those subtle things. One of the things Carole and I lobbied for with this Jewish Healthcare National Patient Safety Board Coalition is to make sure that there was protection for patients and families. There was a pathway for patients and families, and frankly, anyone who wants to report individually to the NPSB, that exists, that it's not just looking at data. It's actually creating this reporting pathway, because when we look at the places where there's been some cover up, it's usually a whistleblower who steps forward and says, you know what, there's something happening in this organization that I'm not supposed to talk about, but I'm going to anyway. So we want that protection and that pathway for whistleblowers to come forward. I don't know if that's a complete answer again to the question, but I think, public reporting, looking at data, improving our counting. I mean, just having that, to underscore that point, but having the CDC look at patterns. I mean, I'm sure this is happening in PSOs. I remember the Veterans Administration, when they first got into the Veterans Health Administration, when they first got into patient safety, they started noticing that there were scalding deaths that were connected to work on the boiler in their hospitals. And, they wouldn't have been able to see that if they hadn't had a lot of hospitals that were comparing data points. I mean, there were like 3 cases, I think, that suggested that there was a pattern or a trend or a risk that could be managed. It wasn't a huge issue, but it was, again, that volume of putting data together and seeing patterns emerge. I mean, it's the same situation for those of you who know our colleague Sue Sheridan's story and the injury that happened to her son, her newborn son, in 1995. It was untreated neonatal jaundice leading to brain damage. We didn't know about that until mothers spoke up and started connecting with one another, because it was a rare enough disease that it wasn't getting reported anywhere. So just engaging the public in safety, giving them a place to go to report, looking at data sources better, having CDC count better. I think those are all kind of multimodal approaches we could get there. Carole, I do want to answer Brian Elson's question too about Vanderbilt, because I feel like I've defamed them in some way. So Brian, the person who told us that is Jerry Hickston. He's the Chief Patient Safety Officer. I give Jerry a terrific amount of credit for his honesty. I don't know that he was in any way the person who made the decision not to report it, but he answered that question candidly in a couple of different venues, because there is a reporting statute in Tennessee, and they did not report this. And it was also not accurately recorded in the medical record. The medical record did not name the paralytic drug that Charlie Murphy got that killed her. So there was a failure to report, and he's been honest about it.
So there are a plethora of questions coming in. We can't answer all of them, but I think one that has come up quite a bit, and that is, the use of information and technology moving forward. And, when you're reading the literature out there, while technology is great and artificial intelligence, there's still some concern about bias in artificial intelligence and how those will apply. And we always have to make sure that when we turn to technology, we have to keep that human element as part of it. There's just no way that technology can do all the changes alone without the human aspect. As part of our priorities, that is not something that we are focusing on, but when we need to as a collective group, if we need to support or push back against certain things, that's what PFPSUS will often work with other entities that have more information in that area than, say some of us, because AI, informatics, technology is a whole nother subset of healthcare that you have to have the knowledge to make sure that we're not unintentionally harming patients and families. I know we're getting too close to the top of the hour, and there's several other questions that came in there. One of the things that we want to say is, someone had asked, are we just another coalition or group that, are out there and over time we're going to become bureaucratic or morph? our group are patients and families, but we're not just solely patients and families. We're advocates and activists who are physicians, nurses, PharmDs, anybody, whether you've had a phenomenal experience in healthcare or you haven't. It's just becoming a more powerful voice that we can go to government regulators and, say, we want this changed, and we are your public. We're your constituents in many of these cases. So we're asking any and all of you, if you want to become part of the group and work with us, that's what we're looking to do. Patient safety doesn't have we don't have what's the word I'm looking for? A lobbying group. When we try to go against the American Hospital Association, they have an immense lobbying group. We're just a group of people that are trying to get the best care for everyone. And if we're creating our own lobbying group and using our voices to push back.
Carole, I want to cover a couple of things there. First of all, for those of you who are affiliated with the American Hospital Association, you have been fantastic leaders on patient safety in the past. I mean, I can just point to people there that were phenomenal. You were the biggest hand in the Partnership for Patients. You did phenomenal work. You had a war room that I used to go visit because it was just down the street. What happened? Why isn't that prioritization still there? Please bring it back. And especially now, one of the things that we haven't talked too much about is that one of the strategies in the Global Patient Safety Action Plan, WHO's plan, as well as in the Safer Together plan here in the United States, is worker safety. I mean, safe systems protect not only patients and families, but workers. And there is every reason for us to be working together to demand that, whether it's payment or law or all of the things that drag on us having the safest systems we can have for all the people involved in healthcare, whether it's patients, family members, or workers. I mean, there's more that unites us than should be dividing us. And then, Carole, to your point, Patients for Patient Safety is organized to be patient-led. It's always going to be patient-led, but it is open to anybody who wants to be a champion for patient safety. And champion is the word that WHO uses. So if you want to join us, go to our website at pfps.us. There's a join button that's very prominent there. Thank you, Armando, for designing such a nice website for us. We do orientation sessions that are 1 hour long, 3 times a month. And that gets you kind of in the pipeline to become a WHO Global Patient Safety Champion. And that's going to be the network that we increasingly turn to for the advocacy work that we're doing going forward.
So I know we're 2 minutes to the top of the hour. We want to thank everyone for engaging with us today and look forward to seeing what we as a collective group can do to move this work forward. And that, Steve, we'll turn it back over to you to wrap it up.
Great. Thanks, Carole and Marty. This was fantastic. I want to thank everyone for attending today. And we've got you can consider this part 2 coming up next with Armando's keynote on engaging patients and families in quality and safety, a deep, transparent partnership. It starts at 9:10 today. And I want to thank everyone again. And before we leave, Carole, Marty, is there any way people want to get in touch with you that they could at all?
Sure.
Yeah. So that one way is if they want to, they can go to our website, PFPSUS, but then I think our emails are probably out there. If not, Steve, feel free to give them to people. But certainly I know Marty and I share our emails freely and are happy to speak with anyone afterwards.
Great. Well, thank you
I'll just
very
put
much.
my email in the chat too. And Steve, if you would do us a favor, if you could save the chat. Carole, I didn't get to all the questions, but I'd be happy to work with Carole to follow up and get to the people that we didn't ask. Aline, Allison, I mean, they're good friends of ours who are weighing in here. So I'd love to connect to around the chat.
Great. Will do. Well, thank you all very much. And we'll see everyone in 10 minutes.
Thank you for the opportunity.